and affiliation into the chat as you join. That would be terrific, so we can know who's here. And we're so excited to have you all here today. For those of you who don't know me, I'm Elisa Stolberg. I'm the Director for Family and Child Health at the Health Department. We've been partnering for almost 2 years with the Blueprint for Health to support work around pediatric medical homes. And we are now, I think, on session 8 of this training series around pediatric, all sorts of pediatric health topics. Today's session is on youth mental health, and we have 2 phenomenal speakers today. Greta Spotswood, who is the medical director for the Vermont Consultation and Psychiatry Access Program, and Ellen Arrowsmith, who is the program director for Vermont CPAP. And without further ado, I'm gonna, oh wait, I have one more slide before I turn it over. This is a screenshot of all of the trainings that we've done to date and the ones to come. Today, again, is on youth mental health, and next week is on youth substance use. And we have a great panel presentation coming then. So excited for today's content. And now I will turn it over to Ellen and Greta.
Thank you. Hi, my name is Ellen Arrowsmith. I, as Lisa said, I'm the program director for Vermont CPAP. I am an LICSW and a social worker on our team. You might hear me reference later on our team, we call our social workers liaison coordinators. So you might hear me use that language. I serve on that team as well for Vermont CPAP. So we're really thankful to be here with you all today. We know we've had conversations and collaboration with many of you and are really cognizant and thankful for the ways that you've helped to support and promote Vermont CPAP across the state as we've been growing in our work. So just really grateful to be here with you today. And I will hand over to Dr. Spotswood briefly to introduce herself as well.
Hi, I'm Greta Spotswood. It's really nice to be here. I'm the medical director of the Vermont Child Psychiatry Access Program, and we'll have an opportunity a little bit later in the presentation to give you kind of a sample of something we can provide for practices. So thanks so much for your work and for having us today.
Fantastic. And Greta, you just gave me the perfect segue. I was going to give a disclaimer about our name. So some of you may be familiar with the Vermont Child Psychiatry Access Program, and we have recently expanded the scope of our service, which I will speak about briefly here. But we are now the Vermont Consultation and Psychiatry Access Program, but you're in the right place. We're the same group, the same phone number, the same service, just with an expanded scope. And so we're really excited about that. But if there's any confusion about our name, I want you to know that you're in the right place. And just as we get started here, it would be helpful if you could raise your hand or drop in the chat. Just, are you already familiar with Vermont CPAP? If you want to raise your hand or say yes or no, it'd be great to just have a quick temperature check as we get started. And Greta, maybe you can help me kind of keep track of those as they come in. Looks like we're getting lots of yeses. Great. That's fantastic. That's what we hope, and we've been working really hard to help get some awareness. So that's awesome. And hopefully we can just provide some additional context and information and updates about our program as well. So great. Here's our roadmap for our time together today. And we really hope that this feels engaging and conversational. We really invite you to ask questions or raise your hand or drop things in the chat. We know this format with a lot of folks on Zoom is not always the most conducive to feeling collaborative and conversational, but we would like you to feel free to engage with us throughout our time together today. Our hope is to talk briefly about the youth mental health landscape in Vermont. We won't belabor this because we know that you also live and breathe and work in this space, many of you as well, but we'll touch on that briefly. We'll talk a little bit about the unique role of primary care in meeting youth mental health needs and how Vermont CPAP supports our primary care colleagues. And then, as Dr. Spotswood said, she'll be providing just a mini suicide care and primary care training as an example or model of the type of trainings that we're able to provide to practices in our work. And then we hope to have a little time at the end for some questions and discussions. So next slide, please. So it sounds like many of you are already familiar with Vermont CPAP, which is great. We have been around for about 2.5 years now. We are a free rapid access psychiatric consultation service for pediatric and perinatal providers. And really, we are a peer-to-peer teaching service. If you think about the parable of if you give a person a fish versus if you teach them to fish, our goal is really to help teach people to fish in order to be able to provide appropriate mental health care for their pediatric and perinatal patients. And our hope and our goal is that if we are immediately available to provide them with that support and education, that they'll be able to provide immediate support to their patients, and that will help everyone kind of along that continuum of care to feel like they're getting the support and help they need faster and more efficiently. And our overall mission is to harness collaborative relationships and evidence-based strategies to improve mental health care for kids, caregivers, and perinatal people in Vermont. Next slide, please. There we go. Just because I know that you are all a really knowledgeable crew who has a lot of helpful information and insight for us as well, if you wouldn't mind putting in the chat just 1 or 2 words to share with us here. What are you seeing as the most pressing needs in youth mental health in Vermont? And if Greta, if you would help me kind of maybe shout some of those out or report a little bit out, it'd be helpful to kind of see what others are seeing and noticing in that space as well. I'll give that just a minute for those to come in. See, I can see them sort of pop in. I'm not looking at the chat, but I can see anxiety so far.
A lot of anxiety, depression,
Yep.
Homelessness, phone addiction, anxiety, depression. Nobody's voting against anxiety and depression.
Yep, everyone's anxious.
Self-harm, counselor availability, family-centered parenting support, long wait lists for therapists no longer accepting insurance, more providers that take Medicaid insurance for therapy, availability, transportation, access in rural counties, community supports and wait lists, canceled eval appointments.
Okay.
So a variety.
Yeah, no, that's really helpful. It seems like you all are seeing many of the same things that we are hearing about from the providers who are calling into our line. So if you could go to the next slide, please. So it sounds like it's not news to any of you that we're in the midst of a youth mental health crisis in Vermont and nationally. Here's some examples of headlines. We know that there was a lot of attention and focus on this issue, particularly during the COVID-19 pandemic. A real concern about how our children and youth were doing in regard to their mental health, and that has continued. We continue to be really concerned about how our children and youth are doing and navigating in this world that is increasingly complex and challenging. And so we're thinking about things like, as many of you mentioned, things like smartphone use and social media and depression and isolation and all of these things that we know are really difficult challenges for our youth right now. Next slide, please. And this really mirrors, many of the same things that you all were noticing and sharing in the chat are things also that are reflective of the Youth Risk Behavior Survey that's available on the Vermont Department of Health website. We have that linked here. If you haven't already read through that, I really recommend it. There is a full report, and then also there are brief summaries for middle and high school, but it gives a really helpful overview of the types of challenges that our youth are experiencing in Vermont right now. And I think that again, really aligns well with many of the things that you all are also noticing in your work as well. Next slide, please. And we know, so where this is presenting, where this is showing up is where kids and families are, and that just makes sense, right? So that might be at school, and that's also at their primary care provider. And, we hear from our primary care colleagues that sometimes, maybe 50% of the patients that they have seen in a day are presenting with a mental health concern. And that's a real difference in primary care historically. What they might have been seeing and in their day-to-day practice might have been things more like, asthma or eczema or well child visits or those kinds of things. And they are seeing more and more mental health concerns in their daily practice, and the acuity as well, we're hearing of what they're seeing is increasing as well. And some of them, especially in more rural areas, might be the only person on that child's mental health team if there aren't therapists or other resources available. And we know that our primary care colleagues have a real range of comfort and training and experience with treating mental health conditions. Some of them are real champions in this area who feel really confident, and others might have had pretty limited training in their medical training and feel like they need some help and support to really understand the needs and how to meet the needs that are presenting to them. Next slide, please. And so while there are inherent challenges with the scope of the mental health needs presenting at primary care, there's also some inherent benefits to this. We know if we think about our own primary care providers, or if we have kids, our children's pediatric primary care providers, that's who you have a really long-standing, trusting relationship with. I know from my time working in schools, a lot of times I would hear from the PCP that they knew the child, but they had also seen the older siblings or the cousins or mom in some cases. Sometimes there's just that really long historical view and relationship with families that is really valuable to having a nuanced understanding of their needs and situations and what's going on for them. And also, we know that PCPs are really natural advocates for their patients, and that's really tireless and sometimes unpaid work for them and really difficult work. But we know that they feel really strongly about the importance of meeting the needs of their patients. Next slide, please. So in the old pediatric mental health care model, and you can see here our STIC people are our patient panel. And what we know is that roughly half of our patients here will meet criteria for a mental health disorder at some point during their childhood or adolescence. And that roughly 20 to 25% will have a mental health disorder that results in severe impairment. And in this old model, our pediatric primary care provider here would feel pretty comfortable and competent treating pretty straightforward conditions, maybe like ADHD or anxiety. But anything else that was more complex would be referred out to the mental health team or to specialty care. Next slide. But what we know is that in real life, we're not screening or identifying everyone who has needs. So we're missing some people. And also that there's a tremendous amount of barriers and challenges that can present between primary care and that access to mental health care or specialty care. We can think of long wait lists or lack of transportation or broadband internet, or maybe there aren't resources available in the appropriate language, or maybe there are so many compounding stressors for this family that they're just not able to follow through and make it to appointments. But there's really just a million reasons why sometimes families and folks get kind of lost in the shuffle or end up on really long wait lists or aren't able to really efficiently access the level of care that they need. Next slide, please. So in the stepped pediatric mental health care model, what we hope is that primary care providers, and ideally this is in partnership with caregivers and school teams and outpatient therapists, if those exist, but that they feel really comfortable and competent treating mild to moderate acuity mental health needs within the medical home, within primary care. And then what that does, and that's where Vermont CPAP steps in to help provide them with support so that they do feel really comfortable to do that. And then the outcome of that, what that does is that creates more space so that those who need higher acuity care, the higher levels of care, are able to get it faster and more efficiently. So for example, a child who really just needs an ADHD diagnosis is not languishing on the same wait list as, for example, a teenager with emerging psychosis who really needs care and support immediately, that there's a little bit of that differentiation and folks are getting the appropriate level of care, and that helps everyone along the way to get the care that they need faster and more efficiently. Next slide, please. So this is a really well-established model nationally. You'll see this map here is from the National CPAP program. There are similar child psychiatry access programs in 49 states in the United States. And actually, we just got an email from someone in Idaho the other day who is interested in starting their own program. So for better or for worse, Vermont is not alone in this challenge that our pediatric primary care providers are seeing, a real increase in the level of their mental health needs presenting to them. And our PCP colleagues need help and support to be able to meet that need that they're seeing. Next slide, please. So this is our Vermont CPAP team. We like to say we are tiny but mighty. We are a team of child and adolescent psychiatrists and licensed clinical social workers who are available to answer the phone consult line calls as those come in. Next slide, please. And in terms of what this actually looks like or sounds like, some of you might already be familiar, some on the call might have actually called or interfaced with us. But each day of the week, our phone line is staffed, as I said, by a licensed clinical social worker and a psychiatrist working together in partnership. And we aim for there to be like very little we want it to feel easy and efficient and supportive to answer the phone. So it's actually our social workers who are the ones who answer the phone calls. There's no gatekeepers. We want it to feel like you don't have to do a big initial lift to get connected, that we're available to answer those questions that arise immediately. And those questions might be around things like screening and assessment, diagnosis, treatment planning, medication management, and resource and referral support. Next slide, please. And I think it's helpful to see an example of a type of call that we might get. This one says, "Good morning, this is Kelly Smith. I'm calling today because I have a 5-year-old patient who was adopted. He has a trauma history and is having a lot of behavioral challenges in school this year. His parents and teachers are wondering about ADHD. I gave them the Vanderbilts, but the results were inconclusive. I'm wondering if I should try a stimulant for this child." So if this provider called on a Tuesday and I'm the one who's answered this call, right away I'm hearing that they have questions about medications and interpreting the Vanderbilts. So I would be scheduling a consultation with our psychiatrist. But we're also really listening and paying attention to the other pieces of this patient's story and asking questions about, what does it look like at school and at home, and what other resources might be helpful for this family. Maybe that is therapy or parenting support, those kinds of things. Next slide, please. So our team of social workers or liaison coordinators, as I mentioned, we are available to help support with providing psychoeducational materials or information on community-based resources. But I would say the bulk of what we're doing these days, I like to think of us as matchmakers. We help to find therapists for patients when their provider calls us. And we work really hard to not ever provide, a generic list of therapists who no one has checked in on many years. What we know is that when families get kind of those more generic lists or recommendation to just go to Psychology Today, is that they end up feeling really overwhelmed and often quite demoralized when they either don't hear back or they get a lot of no's. And so what we try to do is to reach out to 10 or 20 or sometimes 30 different therapists to do our best within the limited resources that we have, as many of you know, to find a therapist who does have current availability and takes the right type of insurance, and is using an evidence-based modality as much as we're able to ask about that. And we package up that information and we provide it to the primary care provider in an email, so that they can give that to the family. And we've heard, anecdotally from providers that that's been really helpful to connect them with care. Sometimes they say, this family was looking for a therapist for a year and now they're in therapy. So we're still working on how to track data about that, but we do hear anecdotally that that's been a really valuable part of our work in getting folks connected to care. Next slide, please. So we try to think of these patients and families from a really broad perspective, within the context of their family, school, and community. We're thinking about how to accurately understand their needs. And we know, especially for pediatric patients, that takes some time and nuance and care to understand as these kids are developing, what worked a month ago, maybe they grew 2 inches and it's not working anymore. And so we know that needs sometimes some fine-tunement and adjustment over time. We think about medications if those are indicated. Sometimes that's prescribing or deprescribing, just depending on the situation. And then, just broadly, what other supports or resources would be helpful for this family? And that we hear too that just having something tangible and concrete to be able to offer families really helps the PCP as well. Next slide, please. So as we keep mentioning our new name and new expanded scope of service. So I wanted to highlight that this past fall, we merged with our perinatal colleagues. And so now we have one consultation service for both pediatric and perinatal patients, which we're really excited about. And if you think about this from a public health perspective, kind of the line between pediatric and perinatal is quite porous, and it makes so much sense to collaborate. And so we are the same phone number. It's our same team of social workers who answer the phone. And Dr. Sarah Guth is the psychiatrist who is able to do the perinatal consultations for us, and that's been a really great partnership and collaboration. And Eliza works on both sides of our team, providing some support to Dr. Guth. So that's been a really exciting expansion for our service. Next slide. So the model of the service on the perinatal side is essentially the same with that special population that the folks who are calling about perinatal patients, whether they're pregnant, postpartum, breast or chest feeding, or have questions about preconception or just mental health in that perinatal period. We're able to provide both the psychiatry consultation with Dr. Guth and also the same type of resource and referral support. Next slide. And this is an example of a perinatal call that we might get that says, hello, this is a midwife calling. I'm working with a 33-year-old who is 8 weeks pregnant. She has a history of being diagnosed with borderline personality disorder, bipolar disorder, and depression. She stopped taking her fluoxetine and lamotrigine with a positive pregnancy test, but is now experiencing a great deal of anxiety. She doesn't have a therapist, and her PCP isn't comfortable prescribing for her in pregnancy. So again, this would be a collaborative effort with Dr. Guth to help them understand pieces around safe medication during pregnancy, and also thinking about what other resources might be helpful for this patient. Maybe that's therapy or a support group or other psychoeducational information. Next slide, please. So this is just kind of a summary of the overall goal and hope of our service is that when we provided that immediate support to our PCP colleagues, they're able to provide that immediate support to their patients. And then those mild to moderate mental health needs receive really excellent care from their medical home, and some might no longer need to be referred to higher levels of care. And that we hope that then that means that those who do need those higher levels of care are able to get that to that faster and more efficiently. Next slide. We have a lot of great resources available on our website. That is available for, we have a page for providers and a page for caregivers and for outpatient therapists. And we have a training calendar, lots of great information. That's a good way to stay in touch with Vermont CPAP and the work that we're doing. Next slide. There we go. And so in addition to our consultation service, we also provide free trainings to practices. And we have some pre-prepared content areas that are kind of in alignment with many of the top things that you all are seeing: anxiety, depression, trauma, suicide care. But we're also very happy to tailor content that's of interest or need to a practice. And we often do those via Zoom, maybe during a staff meeting. If those are, whatever is of interest or need, we want to be there to help provide support to our PCP colleagues. And we also provide some free or low-cost trainings to therapists as well. When we identify, a gap in who is available to refer to, we want to be sure that we're providing training to our outpatient therapist colleagues so that we have a really robust pool of well-trained folks to refer to when we get those requests. Next slide. So in terms of our impact, with help and support from many of our Blueprint friends, we have registered 100% of pediatric practices in Vermont, and we're really proud of this. We've supported probably close to 1,300 calls. It's hard to keep this slide accurate because our number keeps going up. We have provided a lot of really robust trainings to PCPs and therapists now as well. And what's really important to us is the impact that it's having. And so in a survey that went out to primary care providers who had accessed our service, 85% reported an improvement in the quality of their working life due to services provided by Vermont CPAP. And that's really important. We talk a lot about it, this idea of you don't have to worry alone. We don't want PCPs to feel that they're alone in trying to manage and figure out what to do to meet the mental health needs of their patients. And 60% indicated that if not for a Vermont CPAP consultation, they would have referred patients out to a local psychiatrist. And so again, that speaks to how we're addressing, helping to folks get care faster. Next slide, please. All right, and so this might feel like a hard left turn here, but our hope and our goal with this transition is that we're able to give you an example and a demonstration of the type of training that we might be able to offer to a practice. And also suicide care is something that's a real priority for Vermont CPAP to help to continue to provide information and training on this really important topic. And so now I will hand over to Dr. Spotswood.
Thank you so much, Ellen. I wanted to note in the chat that someone's saying navigation to services for the win. And so that's definitely what we do. And we know that's what you do as well. And so we're really excited to keep partnering together. So this presentation is a presentation that we have available for practices. If they're interested, they can sign up on our website, like Ellen mentioned. It's one of many topics that, as you know, are really important in primary care. So if you could just kind of help me out here, because I don't want to, I want to kind of understand where folks are already with this topic before we jump right in. But if you could just take a minute to think about your biggest question about suicide care for your practice or for your patients or one patient, and pop that in the chat. And Ellen's going to help me out by reading those. So we'll just take a moment to think about your biggest question about suicide care for your practice. I started us off by reiterating the question. Or if everyone's eating, I can just start the presentation. Oh, here we go. Good.
Navigating RSI with parents. That's a really good one that we often get questions about.
I love how you're thinking about supporting the caregiver. Great. And if anything else comes to mind, feel free to pop it in the chat. Next slide, please. So here's an example of someone who may come into your office. 14-year-old African-American bisexual cis female presenting with her father for an annual physical exam. Next. Of note, changes in her grades, sleeping more, and says somewhat for question 9 on the PHQ, which is the one about self-harm and thinking about hurting yourself or killing yourself. No therapy. Next. And also not as hungry, used to play soccer, not anymore. Some significant family history and a recent bad relationship, but not currently in terms of potential trauma. She kind of looks away when these questions are asked about how she's feeling and suicidality, but otherwise she's pretty eager to answer questions and does endorse some suicidal ideation. Next. So providers often think about a differential diagnosis. They'll be thinking about the medical opportunities to intervene and help her out, and also the psychological ones. And I know you guys support these plans as well. And so this is kind of like your basic differential diagnosis based on this history, thinking about depression, PTSD, safety, any learning challenges. Next. Something that I didn't learn when I was in my training, which was less than 10 years ago, was to also think about putting suicidal ideation as its own problem and triaging and treating it as its own problem, not just under major depressive disorder or under PTSD. Next. And the reason we want to really support putting suicide care as a separate problem on the treatment plan and the problem list is that it buys time when we're thinking about suicide care and providing that suicide care. It both buys time to determine and treat the underlying cause of what might be causing suicidality. And sometimes you get there and sometimes it's still kind of a question, or maybe it's one or two things that might be causing the suicidality. But we know that that can be really helpful for both providers to be able to kind of have confidence in supporting something that can feel really scary, and also makes the patient feel really validated that this is something really important. We're not just brushing over it to treat your depression. And also it keeps the patient safe. So lots and lots and lots of good reasons to put it as its separate problem on the problem list. So as you help with treatment planning and care, ideally, as providers are becoming more and more aware of making this a separate problem on the problem list, that will probably trickle over in terms of the needs for patients, which is very cool. And again, the old way was like, do they need to go to the emergency room or not? And the new way is to be really pretty nuanced about how to provide this suicide care. So that's what we'll be talking about today. And because of, just the nature of what we're doing today, a lot of my goal for our time together will be just to be talking about kind of how to access these resources rather than kind of teaching you every little detail about each of these resources that will come up in the slides. Next. Okay, so a little bit of epidemiology next. Suicide is, dying by suicide is the second most common cause of death for youth in ages 15 to 34, the 10th most common cause of death overall, and it's been increasing and rising more for minority youth. Next. And this is really important for primary care in particular because of high rates of depression and high rates on suicidal risk questions. And that primary care is the most likely point of contact for suicidal patients. As you can see, those numbers are pretty high, 45% the month prior. Next slide, please. So let's start with some suicide care strategies. Next. And I already mentioned this piece. When we only treat the underlying cause rather than providing suicide care on its own, we're not very systematic in terms of how we treat this. And we might even stop at the PHQ-9 and say, oh, that's positive. Okay, we'll keep an eye on that. So next. And there's also newer evidence that the sequence of care helps prevent fatal outcomes. So you'll see a lot of some different sequences coming up, and just knowing that these are life-saving sequences. So how can we work as a professional community to provide this care? And this is partly why we're here today. Next. This is our suicide care webpage. We have a whole bunch of different resources, as you can see at the top. So info about the consultation service, and then the resources, and we have our own separate suicide care page. And so you can see at the bottom here, vtcpap.com is our website, and you'll find everything I talk about today and everything that Ellen's talked about on that website. So it's a great resource for you. Next page, please. I guess the biggest question, or the question that came back when I asked about your biggest challenge around providing suicide care was navigating suicidality with parents. And this is the stance that is recommended. And I think this stance would work with parents as well, and just having these frank conversations with both the patient and with the family. So thank the patient for sharing their suicidal thoughts. Offer hope by hinting at resources, but not pushing them right away. I know that oftentimes if I'm not, I don't have practice with something, or if I'm worried about something, I can kind of like hold up the list of questions or the clipboard and kind of grab onto that to kind of help me. But we're thinking about kind of the stance that helps the patient. And so that's kind of a barrier between me and the patient if I'm kind of holding on to my questions so tightly. So you kind of hint resources without pushing them right away. And then asking directly about when and how. And then after that, kind of celebrating resources like, this is so great that you talked about this. Here are all these different options. And then saving the crisis line and making sure there's a next follow-up appointment. So there are nuances to this, which we'll get into in terms of kind of severity of suicidality. But overall, this very open stance has been shown to save lives. So, and doing this with parents, kind of validating that like this makes everyone feel really anxious, but these are the things that they can do to help as well. They can thank their child for sharing. They can mention that they know resources and how to help. They don't have to do this alone as a family. They can ask direct questions about when and how, and then they can celebrate resources together and make sure there's a plan and enough supports on board, whether that means, calling crisis, going to the emergency room, calling their therapist. So we'll go over planning as well. And my guess is that you all have run into some of this information before, but I'm wanting to make sure that you all have access to where to find it, because it's hard to remember all of it all the time. Next. So I won't get into this as well, but again, the essential elements of a suicide care pathway are available on our website. So if there's anyone in your practice who's interested in thinking about the suicide care pathway, or kind of making sure that the suicide care pathway that you have in your practice is as evidence-based as possible, it's right here on our website. So, and we included the link. I think it's clickable when you send out the PowerPoint today. So next. So pulling out the elements that are most specific for primary care are PCP provider education, screening, risk reduction, medication management, and then making sure that the relationships are really strong and leveraging those relationships to save lives. Next. And it's important to kind of organize this for people, because what providers see coming in the door could be a real mix of risk and need. So you can see in this complicated Venn diagram, this is how patients might present with serious thoughts of suicide, suicidal plans, or suicide attempts, and kind of how do you make sense of this without sending everyone to the emergency room, right? And sometimes people do need to be in the emergency room, but we also want to make sure people are getting the right level of care. So next. The way we describe this to providers is that it's on a continuum from non-suicidal self-injury all the way to a suicide attempt. And so that's kind of how you can think about the need and organizing how to support families. Next. So PCP provider education is one of those points for primary care that saves lives. We know that with education, PCPs can feel confident screening and managing suicidal ideation, depression, and substance use. They have increased clarity, job confidence, and they feel more efficacious. And we know that not just one, but repeated educational sessions lead to a decrease in suicide. And so that's important. And so if you're ever in that position to kind of help support the PCP colleagues, just knowing that kind of once will probably not be enough, but having someone talk to them about these evidence-based treatments over and over is what actually leads to decreased suicide. Next. All right, so how are we screening? There was a 2022 task force recommendation. So this is kind of important. saying that we need to be screening for depression for ages 12 and above. So you can go to the next slide. And if there are any risk factors, then also screen for suicide care needs. So we're not, there was no recommendation for or against screening the entire population for suicide risk. But if there are any risk factors, so basically everyone that I'm seeing as a child psychiatrist has a mental health challenge, and so that's a risk factor. So I'm screening everyone for suicide care needs. But in terms of the general pediatric population, we screen 12 and up for depression, and then anyone with risk for suicide care needs. And you can screen with whatever instrument you're most comfortable with or your practice uses the most. Here are some examples: the ASQ, the Columbia. We have the combined ASQ and PHQ on our website. We have other options as well. So next slide. So when you're looking for this, you can see the screening tools right under the suicide care guidelines on our website. And you can see all of these options are available. So again, whatever you're the most comfortable using. And I do like the combined PHQ and ASQ if I already know I'll be screening for suicide risk. Next. And then we kind of go over with providers why we use these questions, and that the questions progress from passive to active ideation. And then there's one question assessing for acute risk if you're using the ASQ, similar for the Columbia. Next. And again, these evidence-based pathways save lives. So here is the screening pathway, and you can see it tells you exactly how to go on the right pathway, whether it's low risk, further evaluation needed, or imminent risk. And oftentimes it is that further evaluation needed, where we're all thinking together about, okay, when is the therapist available, or is first call available right now? And so those are often the places where we get a lot of questions. If you call our line and there's imminent risk, it's very clear that the patient needs to go to the emergency room. We actually don't get a lot of those calls, which is good, because we want people to get right to the emergency room, or right to first call, or to your designated agency's urgent call line. So we don't help with the imminent risk, but our phone line does help with a lot of the kind of medium risk, where it's like a gray area, and then we can help talk through resources. And you can see there's a brief suicide safety assessment before that, and that helps you figure out where you are on that path. And again, this is all available on our website. Next. All right, so evidence-based for risk reduction in primary care includes safety planning, lethal means reduction, and CALM. Next. And there's fortunately a safety plan template. If you have used this, you know how easy it is. This is a Stanley Brown. And if you haven't, it is easy. At the top, you can see warning signs. Next is coping strategies. Next is crisis resources. It looks like on this example, we need to update that number to 988. And then the next is lethal means restriction. And then sometimes older versions don't have that last question, but the protective factors question is also really important. The one thing that is most important to me and worth living for. And there are also online versions of this. And these are evidence-based. I like the paper copies if you're able to, but if the patient prefers to have something on their phone, there's definitely online versions of safety planning. And then everyone gets a copy, like the PCP office gets a copy, the therapist gets a copy, the family gets a copy. And this is just maybe right next to the patient's bed, so that, if they start having urges, then they know exactly, they've already thought through what to do. And so that's how this works. There's also a virtual hope box where a kid makes their own hopeful pictures and reminders of the safety plan. And you can see the link right here on this slide as well. Next. All right, and what do we do for risk reduction? Having a lock box or locking cabinets is really important. Having gun trigger locks, education about safe gun storage, and removing items from the home is also really important. So these links are really helpful for risk reduction as well. Be Smart for kids walks families through all the ways they can reduce risk. And then counseling on access to lethal means is a two-hour free training that any clinician can do around risk reduction. So I'd highly recommend it. I think everyone on our team has done this training, and it's definitely worth it. Next. Medications are also important. So when I'm talking to providers, I'll talk about more specific medications, but there is no medication to treat suicidal ideation specifically. At that point, you're treating a suspected underlying cause. So you don't want to just give a medication just because of suicidality. But oftentimes the medications take a while to work. And so as you're treating that underlying disorder, you also want to still be supporting the suicidality. So that's kind of the take home for that one. Next. And then relationships, and this is important for you all, because you have that patient-facing time. And so relationships around care transitions, leveraging relationships with caring contacts, and then knowing which psychotherapies are evidence-based and kind of having the patient be able to have that really open relationship with their therapist and using your relationship with the patient to promote therapy for patients is important as well. So next. So care transitions, during care transitions, we know there is increased risk of suicidal actions. So especially around the psychiatric inpatient or emergency room transition to the outpatient setting where primary care is. So we want really close and tight coordination between systems. If a follow-up visit is missed, contacting the patient is really, really important. And having frequent check-ins around this time and caring contacts can help with that. I was really excited to learn about caring contacts when I was learning more about suicide care, because they're kind of a really easy way to leverage that relationship your practice or the PCP or you might have with a patient. And it's really cool that caring contacts actually saves lives. So that piece I think is really cool. So we'll look at that in the next slide, I think. Let's see. Yep. So caring contacts is using this perceived relationship between the PCP office and the patient. And they can happen with postcards or telephone calls that are sent at several specific times after the patient's been identified as at risk of suicidal ideation or suicide attempt. And so it's a really important part of suicide care. They're very brief messages and very non-demanding. You can even give the patient the first message when they're in the office. And these are examples of messages. There are more examples on nowmattersnow.org. So Danielle, I have much hope for you. I think that what we worked on today and this website will be helpful. I look forward to seeing you again. I'll remember what you said about your daughter. With care, Zioshan. And then Now Matters Now is just right there on that particular caring contact. And Now Matters Now is a really great website that we enjoy promoting because it's really patient focused. Or person focused. It's really non-demanding. It's kind of like these caring contacts, and it just has all of this evidence-based suicide care right there for the patient. So that's one way to do it. And then some practices, when looking at the literature, it looked like some practices were sending these by text. Some practices don't want to do that, but would send, like a letter. And you can see they're not saying, come to your next appointment. That would be like the anxiety of the provider. Please come back and see me. But it's just like, oh, I'm thinking of you. I thought this was really important. And it's super cool because it saves lives. Next. All right, and then kind of moving on into psychotherapy, we know that risk assessment is not an exact science, and so calling on behavioral health colleagues for a second opinion or help with decision making can be really helpful. There's a card called the SAFE T card that can walk PCPs through what to do if there is no behavioral health provider available. So the primary care provider has that relationship with the patients, and then using that relationship can connect the patient with a local crisis line or a local therapist if one is available. And so again, if there is any kind of bump in the road along the risk assessment pathway, it's really important to reach out for help. Next. And so one type of therapy that is super evidence-based for suicide care is called collaborative assessment and management of suicidality. There's a list of therapists that are trained in this, in the CAMS model. And is that list on our website as well, Ellen? It sure is. You can also call our line and see if there's anyone available with that training, if this level of care is needed. So if someone is able to do this model of care, it decreases SI in about 6 to 8 sessions, and an average of 10 sessions is needed. And it's relatively inexpensive, and clinicians learn it pretty quickly. And you can see that link at the bottom is the directory of CAMS trained clinicians in Vermont. And if anyone in your practice is interested in becoming CAMS trained, there are often like free or low cost trainings available. And so we usually promote those on our website or in our newsletter, but you can also just give our line a call, and we'll figure out when the next training is available, or put your name on a list to make sure we can get in touch with you when it's available. Next. Other types of evidence-based psychotherapies that are evidence-based for suicide care are CBT, DBT. Those are kind of the more manualized, kind of faster approaches in my understanding. There's also problem-solving therapy or mentalization-based treatment, growing evidence for that one for people with personality disorders, and psychodynamic interpersonal therapy. So these are all the therapies that we're thinking about when we're looking for good fit therapists for patients who need this care. Next. And maybe at the end, we can answer some of these questions. So again, just reminding you of the stance that can be really helpful. Again, just, my first inclination is to have that clipboard and kind of go through all the questions, but kind of this open, thankful stance is one that works better for patients. And so me knowing that is actually, then I cling to the stance instead of the questions. So I think that can be really helpful to remember. And then next. Lastly, really quickly, we'll just look at system opportunities so that we have like a few minutes for these questions. Next. Just remembering kind of how mental and physical health integration is happening in your clinic helps you understand like where there are systems opportunities, for example, where to put care and contacts into your workflow. Next. And then some funding resources. Again, this is all available on our website. Next. Here are the CPT codes for this type of care, and then you can see when these codes are used by other practices here. Next. And making sure that providers remember expressions of listening and caring were more important than finding an immediate solution to their problems when providers are providing suicide care for patients. And a kind of empowering workplace culture is important for that. Next. All right, so there are questions here. Who gets, maybe Ellen, you can help me here. Who gets the CAMS training? Yeah.
Oh, who gets CAMS training? That's recommended for mental health providers. So it's not necessarily one that, that PCPs would necessarily do, because it is a therapy modality that you would usually do within the context of therapy. And so then I linked
everyone can do the CALM training, and then therapists can do the CAMS training. Yep.
And Elisa, you can chime in here if we need to wrap up and do the evaluation, or if we have a minute or two here. We were just curious. It sounded like at the beginning when we asked folks who was already aware of Vermont CPAP, that many of you already are, which is amazing. We were just curious if you were connected to a practice that serves pediatric perinatal patients. Are they aware of and using Vermont CPAP service? But I think we can maybe skip over that one since we got a little bit of pulse on that earlier and we're short on time. If we could go to the next question. So some practices have recommended a consultation with Vermont CPAP as a part of their internal workflow. So maybe they're one of those really lucky practices that happen to have, a psychiatric nurse practitioner or other resource, and we know that that's a really precious and valuable resource. And so maybe a call before a referral to that person, or maybe that would make sense. But we just want to be available and sensitive to how we can help and support practices in whatever way might work best for them and their unique workflow. But if anyone had any ideas and wanted to put in the chat or go off mute and just talk briefly about this question. How do you see a Vermont CPAP consultation being helpful in your existing workflows?
Hi, this is Corinne Drosen. I'm embedded at South Burlington Family Med. And I just had a question because this all sounds amazing and great. And kind of, I put my question in the chat, and I think what would be helpful is some clarification around if only the primary care physicians have the ability to access the line to kind of like refer patients to the community liaison, or is there a way that us, aka I'm a social work care manager, call and refer, just because I feel like sometimes providers, as you noted, are very spread thin and don't always have the time to then call to consult or help kind of refer. So I was just curious around that.
That's such a great question, which we've been thinking about as well. Previously, it was just providers, and Ellen, correct me if I'm wrong, but now we have been working with like care managers for the referral questions. If it's a question that the provider, wants to talk about medication or something like that, we still want the provider to be the one that we're talking to. Is that right, Ellen?
Yeah, yes, I would say the vast majority of the consults that we log are through the primary care provider, just because we know that they are the ones usually holding the big picture of care for that patient. But we also want to be mindful of their time. And so sometimes it has happened more often recently that care coordinators call and schedule a consultation on behalf of the PCP, or they have a pretty straightforward resource and referral question about how to connect their patient to therapy. And we've been able to log those under the care coordinator as well, although we kind of think about sometimes whether it makes most sense to connect it to the PCP or the care coordinator. So we can talk about those pieces as well. But I would say, when in doubt, if you have a question, if you need help or support, give us a call and we'll make sure you end up in the right place and get the help and support that you need.
Thank you.
Ellen and Greta, we're at 1:00. That was amazing. I can't, I have spent the better part of 3 years with the both of you, and I learned so much today. So really just so much appreciate your time today. I put a link to the evaluation in the chat. I'll try and pull it up here. Probably can't get it quickly enough. And we'll also follow up with an email for folks to fill out the evaluation if you can. Here's how you get in touch with Greta and Ellen and the team. And thank you all for being here and for the work that you do in support of your patients and families. And thank you, Greta and Ellen. This was exceptional. And we'll see you next week. Thanks, everyone.
Thanks for having us. Take care.